Good morning. Today I have the honor of Professor Horst Sievert visiting us. We did a procedure today together, and I wanted to ask him what he thought about the Closure AF trial and if there still is a role for percutaneous LAA closure.
Well, LAA closure is around since more than 20 years now. And there had been multiple studies, registries, randomized trials. All of them had been positive. This is the first trial which was negative. So to answer your question very shortly, yes, LAA closure still has a role.
Okay. How do these data compare to the pooled, the Protect AF and Prevail data, which have led to the approval?
Yeah, they are just not comparable because the patient population was totally different. The mean age was 5 years higher. The frailty was much more pronounced than in any other trial. And also the results from the technical outcome, from the clinical outcome, had been not as good as in other trials, mostly because this is just a different patient population. May also be because at the time when the study started, some of the centers had not that experience, which is common today. So I think all these factors played a role. And I mean, you have to imagine if you test a prophylactic procedure in a very frail patient population, you cannot succeed because the outcome is more depending upon the frailty and the comorbidities than about the procedure. So I think these have been the main reasons why the trial failed.
Okay. How do you manage anticoagulation once you've closed the left atrial appendage?
Well, it really depends upon the individual situation. So in the past, in the US, all patients received anticoagulation. In Europe, all patients received DAPT. Now we adapt this to the individual situation. If the patient can tolerate, there's nothing against anticoagulation for a couple of weeks or months. If the patient does not tolerate it, then we give only DAPT. If the patient does not tolerate that, we give only aspirin or Plavix. And if the patient cannot tolerate anything, then we leave the patient without anything. So this is possible.
Or you do a surgical thoracoscopic HE clip where we can discontinue everything.
Or we do this percutaneously with the Lariat system.
Okay, so we have different options.
Yeah.
Okay. Yeah. Do you perform these procedures on the same day discharge program?
Yes, patients go usually it depends upon the time of the day when we do the procedure. If the procedure is done in the morning, patients are discharged in the afternoon.
Okay. And how are the new technical adoptions, the new devices?
Still early stage. So currently available in Europe is only the Watchman Flex, the Amulet, and the LifeTech occluder. All others are in early clinical trials. I think some of them are really promising. For example, the appendage technique, where we invaginate the appendage and ligate it from inside. Basically, nothing is left behind beside of the suture. I think this is very interesting. Others are still early stage. There's one device I like very much, but it's not in a trial in Europe yet. That is the SEALA device, the e-SEALA device, which can do ablation of the appendage at the same time when we close the appendage. So that's very interesting.
Okay.
All this, again, is not available yet.
So you think there's an important role of isolating the appendage?
I think so. If you are there anyway, at least in my limited experience with AFib ablation, it's difficult to isolate the left atrial appendage. But it may be an advantage. Several trials have shown that, you know that better than I do, that the isolation of the appendage is helpful. And if you can combine this with LAA closure, I think that's a very nice idea.
In my little experience, when we clip the left atrial appendage, and we've published this, the appendage dies off and is electrically silent. So and I think that explains also the results, the positive results, surgical ablation. So thank you very much for this brief interview, and let's continue the good work in the appendage space together.
Thank you.
Ciao.